This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2018, all rights reserved. My name is Shauna Strickland. I am a registered respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Respiratory Care in Pulmonary Hypertension. Upon completion of this AARC webcast, participants will be able to review the classification and mechanisms of pulmonary hypertension, discuss the role of the respiratory therapist in the diagnosis, risk assessment, and treatment of pulmonary hypertension, and review the pharmacologic and non-pharmacologic treatment options for pulmonary hypertension. I am pleased to welcome Dr. Robert Walter. Dr. Walter is an Associate Professor of Medicine at LSU Health in Shreveport, Louisiana, where he is the Section Chief for Pulmonary Critical Care and Sleep Medicine. Dr. Walter established the organization's Pulmonary Arterial Hypertension Clinic in 2007. Dr. Walter has no relationships to disclose. I disclose that I am an employee of the AARC. Brand names of products and/or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis and to provide information and education regarding the availability. Dr. Walter, welcome to the program.
Thank you. It's a pleasure to be here. I have to admit this is my first time to do web-based lecturing, so I hope everyone is patient with me. As Shauna said, we're going to use a case-based approach and review the classification and mechanisms of pulmonary hypertension. And particularly, I hope that people leave with two understandings. One, particularly that pulmonary hypertension is not a particular disease, but rather a manifestation of a number of different conditions. In contrast, pulmonary arterial hypertension is in fact a specific disease that causes pulmonary hypertension that has a unique pathogenesis and a unique treatment approach. We'll also discuss the role of the respiratory therapists who are integral in the diagnosis, risk assessment, and treatment of the PH patient. And this particular patient population is actually a joy to work with. It is a disease that you can modify the outcome and have a substantial impact both on quality and duration of life. And we'll talk a bit about the pharmacological and non-pharmacological treatment options available to these patients. I learn best when I talk about patients that I've seen before, and so I'm going to take that approach. This is a gentleman that I saw a number of years ago. He was 32 years old when he came to me. He worked for UPS, and he noticed that it was getting harder and harder to keep up with his route. He had progressive dyspnea. He had some essential hypertension that was well controlled with medications. His social history was pretty unremarkable. He'd done no IV drugs in the past or other illicit medications and hadn't taken diet medications. He had no personal or family history of venous thromboembolism, and there was no one in his family who had pulmonary arterial hypertension or had early cardiac demise. As we reviewed his systems, he didn't have any rheumatological complaints, no swollen joints, no plaque alopecia, no rashes, and he didn't have any signs or symptoms of venous thromboembolism. He didn't have anginal symptoms. He was just short of breath, and he didn't have any daytime sleepiness consistent with a diagnosis of obstructive sleep apnea. His exam, his vitals were mostly unremarkable. He underwent a 6-minute walk test where he was able to cover about 300 meters, which is about 40 to 50 meters less than one might expect for a gentleman of his height. And he had some mild desaturation, about 91%. He didn't have overt findings of right heart failure in that he didn't have jugular venous distension or lower extremity edema or increased abdominal girth, but he did have cardiac findings consistent with right ventricular pressure overload in that he had a right ventricular heave. He had an accentuation of the split in the S2 sound with a loud P2 component to that. At this point, we were fairly suspicious that he had pulmonary hypertension, and so we obtained a chest X-ray. And indeed, the chest X-ray had several findings consistent with right ventricular pressure overload. Particularly, his right heart border was well into the right side of his chest, and he had loss of the aorta pulmonary window. At this point, we wanted to confirm the diagnosis of pulmonary hypertension, and he had an echocardiogram. The echocardiogram is particularly useful in the assessment of a pulmonary hypertension patient because non-invasively, you can get an estimate of the right ventricular systolic pressure. His was estimated to be about 80. The echo, by looking from the longitudinal axis, gets a sense of what's the gradient between the right ventricle and the right atrium. If there's a big gradient, the tricuspid regurgitant jet there in that formula labeled TR is much faster because of that big pressure gradient. That pressure gradient between the right atrium and the right ventricle added to the right atrial pressure tells us where the RV pressure is. Additionally, you can find findings consistent with RV pressure and volume overload in that the RV may be very dilated, the right atrium may be very dilated. Once you've made a diagnosis of pulmonary hypertension, you need to sort out what category that patient is in. To do that, you have to have an understanding of the classifications of pulmonary hypertension. Historically, we used a classification scheme that had primary versus secondary pulmonary hypertension. This was very confusing in that their primary pulmonary hypertension looked very similar to a bunch of secondary pulmonary hypertension diseases and looked very different than the others. As a result, the WHO gathered people together to reorganize the classification system, and they came up with a format based on the pathophysiology and the histology of the disease. They fiddle with it on a regular basis, alternating the sites where the conferences are. The most recent one was in Nice, France. They assemble in nice places, and we're awaiting for the results of the sixth conference. The schema is listed here, where you see there are basically 5 groups with pulmonary arterial hypertension being group 1. Group 2 is pulmonary hypertension due to left heart disease. Group 3 is pulmonary hypertension due to lung dysfunction and or hypoxemia. Group 4 is chronic thromboembolic pulmonary hypertension. And Group 5 is a general wastebasket category where things that just don't fit neatly into any of the first categories are placed. Memorizing this is a little bit of a challenge, and it's easier just to consider what exactly was it that they were trying to do. They were trying to histopathologically and pathophysiologically put people into groups that made sense. Group 1 is an endothelial cell disorder, and we'll talk a little bit more about the pathogenesis of this disease. Group 2 is anything that causes left atrial hypertension, anything from systolic or diastolic heart failure to valvular disease. Basically, what's happening in this category, the left atrial pressure is pushing back into the lungs and causing the right ventricle to have to generate more force to push the blood through the lungs. This is also known as post-capillary pulmonary hypertension. Group 3 is the loss of functional alveolar capillary units, driven and sometimes driven by hypoxemia. So this is really intrinsic lung disease. Group 4 is chronic thromboembolic pulmonary hypertension, or as many people call it, CTEPH, and Group 5 is everything else. Again, while these groups neatly cluster, it can be hard to remember the rationale for each of them and which group is which. until you understand why they link them together in this order. WHO Group 1, or WHO Group 1, is pulmonary arterial hypertension, and they chose it to be Group 1 because that's really what they were interested in when they assembled. Then, anatomically, they started off at the left atrium, and this is a cartoon I use to explain to patients what's going on. In the left upper corner, you see a cartoon of the right atrium and the right ventricle going out into the pulmonary artery, and the lollipop hanging down is supposed to be a cartoon of an alveolar capillary unit. Then that blood, having gone through the lungs, comes back to the left atrium, left ventricle, and then circulates around to the right atrium. So they started off, they got Group 1 because that's what they were interested in, and anatomically started off at that left atrium. So left atrial hypertension is Group 2. Group 3 is anything that causes hypoxemia or loss of functional alveolar capillary units. Group 4, we're back into the pulmonary artery with chronic thromboembolic pulmonary hypertension. And again, Group 5 is just everything else that's not otherwise classifiable. So let's return to our patient. Might he have Group 3? It's important to remember that an elevated pulmonary vascular resistance is in fact a normal response to hypoxemia or intrinsic lung disease. Effectively, the pulmonary arterial bed is trying to match blood flow, or Q, to the ventilation. And if you've lost a bunch of functional alveoli or they're hypoxemic, those pulmonary arteries will clamp down to send blood to other more functional units. As a result, if enough of these arterioles are clamped down, you've increased pulmonary vascular resistance across the entire circuit. And as a result, the hemodynamics at right heart catheterization are indistinguishable from people who have WHO Group 1 disease or pulmonary arterial hypertension. This elevated pulmonary vascular resistance causing pulmonary hypertension can happen in common diseases like COPD and ILD. It can happen in people who have alveolar hypoventilation syndrome or obesity hypoventilation syndrome, where you see elevations in PCO2. Serum bicarbonate actually is a useful screening test. If their serum bicarbonate is less than about 28, you've got a pretty good idea that their PCO2 is probably normal. For people who have obstructive sleep apnea, there's an ongoing debate as to whether or not severe sleep apnea can cause pulmonary hypertension. But the general consensus is that most people feel like absent daytime hypoxemia, sleep apnea is not a substantive cause for pulmonary hypertension. And our patient in particular, his history did not suggest any intrinsic lung disease. He didn't have any wheezing or atopic symptoms or other exposures associated with ILDs, and he didn't have any daytime sleepiness. And his exam was not consistent with intrinsic lung disease. He didn't have any wheezes or ralls. So having had a bedside evaluation, we also need to get more formal testing. And to do more formal testing, good quality pulmonary function tests are really essential to the diagnosis of pulmonary arterial hypertension. It's essential that we appropriately classify patients, and so good PFTs are really very important. And in our patient's case, his spirometry did not show any evidence of airways disease. His lung volumes were normal, suggesting that he had normal lung compliance, normal interstitium, et cetera. And his diffusion capacity was reduced, which was confirmed by an elevated AA gradient on arterial blood gas. So it's useful to review why people get hypoxemic. At altitude and hypobaric conditions, people will be hypoxemic. Living in Louisiana, the highest point is Driscoll Mountain, which is 535 feet, so that clearly wasn't his issue. Hypoventilation, we saw that he did not hypoventilate based on his blood gas, and his PFTs did not suggest that there was a diffusion defect in that his lung compliance was normal. So we were left with shunt or VQ mismatch, with VQ mismatch being the most likely etiology of this hypoxemia, as it's the most likely etiology to hypoxemia in general. So if he had had group 3 or intrinsic lung disease, then what do you do about it? Well, you got to treat the underlying disease. Inhaler technique, of course, is critical to airways disease control, and the respiratory therapist plays a key role in making sure that people are using their MDIs properly so they know how to keep themselves out of trouble and to get themselves out of trouble. As Medicare is starting to look at COPD readmission rates and you look at strategies to prevent readmissions, you see that respiratory therapists really are going to be the foundation of around whom the COPD readmission prevention strategies are being built. It's important if someone has WHO group 3 disease and pulmonary hypertension from that you do not use PAH-specific medications. There have been a number of trials in people, particularly with ILD, to see whether or not maybe these drugs might work. And it was found that while they might actually change some of the cardiac physiology, you could get worsening hypoxemia. Using PAH-specific medications that are all pulmonary vasodilators, so you end up undoing the VQ matching that the lungs did to make it so that there was ideal VQ matching. And we can see profound hypoxemia at maximum doses of some of these medications. So you really don't want to use the PAH-specific medications in people with WHO group 3 disease. So our gentleman does not have WHO group 3 disease. So might he have group 2? Well, there is a significant overlap, but the demographics and clinical characteristics of people who have left atrial hypertension tend to differ from those who have pulmonary arterial hypertension. And we'll go over that in a little bit more detail in just a second. Additionally, the echo can also give us some hints. You can't directly measure left atrial pressure non-invasively. You can only do that with right heart catheterization, but there are some findings on echo that may suggest left atrial hypertension. The simplest of these is left atrial size. So when I look at an echocardiogram, the first thing I look at is to see what is their left atrial size. If it's enlarged, there's probably pressure and volume overload in the left atrium. Diastology is also measured. They do Dopplers, tissue Dopplers and things like that, and you can see its systolic function also. So those kind of things might hint that somebody has left atrial hypertension. And our particular patient, he had normal systolic function with a normal ejection fraction, and there really weren't any findings suggestive of left atrial hypertension. As I said, the people who get WHO group 1 or PAH tend to differ from people who have left atrial hypertension. People who have PAH tend to be younger on average. The median age is somewhere around 45 years old. And women tend to be affected more often than men. In most cohorts, that's about their rate is about 2 to 3 times higher than the men. They also have risk factors that are relatively unique compared to left atrial hypertension. About half the people have no other diseases, but the other half of people tend to have connective tissue diseases, most notably systemic sclerosis or scleroderma. HIV and portal hypertension have been associated with PAH, as have anorexogens and some other drugs. Liver disease is another contributor to people's risk of pulmonary arterial hypertension. In contrast, people who have left atrial hypertension tend to be older, they're more likely to be male, and they tend to have the metabolic syndrome with essential hypertension, diabetes mellitus, obstructive sleep apnea, and hyperlipidemia. Group 2, at least in Louisiana, is probably the most common reason that people have pulmonary hypertension by echo. We can't be sure whether or not this gentleman that we're talking about has that because we don't have a direct measurement of his left ventricular and diastolic pressure. Again, that takes right heart catheterization to be able to know, but it's nothing so far is suggesting that he has that. It can be hard, even by right heart catheterization, to differentiate between group 1 and group 2. Sometimes the pulmonary hypertension is just passive. That is, their pulmonary vascular resistance is normal. The left atrial pressure is high, and that forces the pulmonary artery pressure to actually be elevated to get the blood flow across the lungs. In contrast, if somebody has pulmonary hypertension for an extended period of time from left atrial hypertension, the muscles of the pulmonary arteries become hypertrophic. They get a lot of exercise, and as a result, they get enlarged. And as a result, they actually can end up having elevated pulmonary vascular resistance. If this finding is there in somebody who has WHO group 2, it's associated with much worse outcomes. The median survival in people who have reactive pulmonary hypertension from heart failure with preserved ejection fraction have a life expectancy on the order of about 18 months. In general, the hemodynamics of pulmonary arterial hypertension have a higher pulmonary vascular resistance and have a lower pulmonary capillary wedge pressure, or our estimate of left atrial pressure. But there is a tiny amount of overlap at the margins. So, if he doesn't have group 2 and he doesn't have group 3, might he have group 4, that is CTEPH, or chronic thromboembolic pulmonary hypertension? He had no personal or family history of venous thromboembolism, and we did both a VQ scan and a CT pulmonary angiogram that did not show any evidence of pulmonary embolism. These are some images from his CT pulmonary angiogram, and we didn't see any evidence of CTEPH, but we did see pretty marked evidence of right ventricular volume and pressure overload. Particularly, his right atrium was gigantic. That ought to be much, much smaller than it is. And his right ventricle was actually much larger than his left ventricle. And normally the right ventricle is a little bit of a crescent around the outside of the larger left atrium. And he actually had reversed that so that the RV was much bigger than that LV. If you go up a little bit higher on the cuts, you see where his aorta is, and really the pulmonary artery ought to be smaller than the aorta, and in his case it was probably about 50% larger. And both of these suggest that actually he had right ventricular pressure and volume overload. So what is CTEPH? It's group 4, and it's chronic thromboembolic pulmonary hypertension. It's a bit of an interesting diagnosis, and there's more attention being paid to it now. It's not clear that it is embolic, so it may actually be that it's a misnomer. And we get that suggestion from the fact that not all pulmonary emboli cause chronic pulmonary hypertension. In fact, people who have pulmonary hypertension during an acute pulmonary embolism, only about 5% of those people 1 year later will still have pulmonary hypertension with appropriate therapy for their clot. And that's without therapy for pulmonary hypertension. And in some not animal models, but cell-based models, it appears that the endothelium of the pulmonary arteries of people with CTEPH act more like fibroblasts than like endothelial cells, and they allow platelet aggregation. So this may actually be a disease where platelets are aggregating, attaching to the pulmonary arteries, and slowly narrowing. And anatomically, one of the reasons that's important is that they end up, rather than just obstructing a clot, they end up with this circumferential sort of sometimes web-shaped clot obstructing the pulmonary arteries, and that can influence treatment. In CTEPH, it fortunately is often a surgical disease with surgical cures happening in a plurality of the patients. When you have the right surgeons doing it, the mortality is on the order of that of a coronary artery bypass surgery, around 2 to 5%, depending on the population that you're working on. They're working on new technologies, including balloon angioplasty. Angioplasty is probably, again, a little bit of a misnomer in that they don't go out and just dilate the pulmonary arteries. They pass a small balloon beyond these webs and inflate it and then pull them back and break up those webs. And that's been associated with improved hemodynamic symptoms and functional capacity beyond their baseline, but there haven't been any randomized controlled trials. If someone's being considered for surgical treatment, you really want to make sure that they go to a center where they're doing at least 10 of these cases a year. And University of California, San Diego is responsible for a significant percentage of the pulmonary endarterectomies that are done, and they're probably the best recognized center. If someone's not a surgical candidate, they still can be treated medically. There's only one drug out that has FDA labeling for CTEPH, but there is clinical experience with the other PAH-specific medications. While there are not very many randomized controlled trials, and their outcomes are surrogate outcomes rather than mortality, and they have limited follow-up, there is a suggestion that CTEPH responds to PAH-specific medications, and people tend to do better with medical therapy than you would expect if you did no therapy. The diagnosis of CTEPH is really made based on multiple radiological modalities. The imaging on the left you see are perfusion images, and when you look at it, there's a little bit of irregularity to it. However, the accompanying CT on the right shows a large clot sitting down in what is the patient's right base, but is on our left, with only a scan amount of contrast getting through, which is where the blood is. In this discrepancy you see between the VQ scan and the CT pulmonary angiogram would suggest to me that in fact the two tests are complementary rather than exclusive of each other. Some centers even use MRI angiography to assist with the preoperative evaluation of patients. So we have decided that our patient doesn't have WHO Group 3 or Group 4 disease, and we're left now trying to figure out whether he has Group 1 pulmonary arterial hypertension or Group 2 left atrial hypertension. To make the distinction between the two, you have to use right heart catheterization, which is synonymous with placement of a Swan-Ganz. What happens is you put the catheter out, and it goes through the right atrium, and there you see a right atrial pressure wave tracing where you see A waves and V waves and X and Y descents. It then passes through the tricuspid valve into the right ventricle, and you see a sharp step up in the pressure tracings with no dicrotic notch, with descent back down to 0. In this patient, the pressures are normal with a RV systolic of about 25. It then crosses out the pulmonic valve into the pulmonary artery, and you see that pulmonary artery tracing where now you see a dicrotic notch, which is the pulmonic valve closure, and a slower descent, which is the capacitance of the pulmonary arterial bed. Ultimately, the balloon ends up in what we call wedge position, where it's wedged into the pulmonary artery arteriole and has made it so there's no distal flow. Absent flow, there's a pressure equalization between the blood at the tip of the catheter and the left atrium. And if you compare the pulmonary artery wedge tracing with the right atrial tracing, you'll see certain similarities, although the pulmonary artery wedge tracing seems to be somewhat dampened. And that's because it's a surrogate for left atrial pressure. And again, in this patient, that's normal at about 12. So our gentleman underwent right heart catheterization to see whether he met the diagnosis of pulmonary arterial hypertension. And you see that the definition of WHO Group 1 pulmonary arterial hypertension is a mean pulmonary artery pressure of greater than 25 millimeters of mercury at rest with a normal pulmonary arterial wedge pressure and an elevated pulmonary vascular resistance greater than 3 Wood units. If you're old like me and think about dynes, it's 80 times to get back to dynes, and that they don't fit into any other of the groups. The implications of that final phrase is that PAH is a diagnosis of exclusion. Right heart catheterization really is the last step in making a diagnosis. If you've become convinced that the person has bad mitral stenosis or they have severe COPD, you don't have to end up doing the right heart catheterization. You've made the alternative diagnosis, and you can just treat them. So his hemodynamics are consistent with the diagnosis of pulmonary arterial hypertension. He had an elevated right atrial pressure of 24 with an RV pressure of 75/4 and a pulmonary artery pressure of 75/31, giving him a mean pressure of 47. His pulmonary capillary wedge pressure, or pulmonary artery occlusive pressure, was 14. So you see there that his mean pulmonary artery pressure is greater than 25, and his cardiac output was 4.86 liters, or an index of 2.5, and that gives him a pulmonary vascular resistance of 586, well above the 240 dynes necessary to make that diagnosis. And as we've worked through his case, we see that he does not fit into any of the other categories. Vasodilator testing is another point where respiratory therapy plays an important role in the diagnosis, risk stratification, and treatment of PAH patients. We do vasodilator testing because it identifies patients who have a better prognosis. Those patients are more likely to have a sustained beneficial response to calcium channel blockers, very high doses, typically of verapamil, diltiazem, or some of the older generation dihydropyridines. The last reason to do it is that most of the pharmaceutical companies, insurance companies, won't pay for epoprostenol unless they have been shown not to be vasodilator responsive. Fewer than about 3% of people will actually be vasodilator responsive. And if someone's hemodynamically unstable, it's usually not required that you do it. Respiratory therapy here at our institution actually helps us out a lot in that we use inhaled nitric oxide as a vasodilator. It's equally appropriate to use epoprostenol or adenosine, but nitric is for us is a lot easier. What we do, there's no established protocol, and each center tends to do things a little bit different. We will either use a face mask or a nasal cannula and start at 10 parts per million and go up to 80 parts per million while repeating hemodynamics about every 5 to 10 minutes. One should not use calcium channel blockers or nitrates as they will get you into hemodynamic trouble and are not as specific a pulmonary vascular vasodilator. You are looking for a decrease in the mean pulmonary artery pressure by at least 10 to less than 40 while the cardiac output isn't falling. That means that if someone's mean pulmonary artery pressure is 65, it has to fall by at least 25 points without dropping their cardiac output before you would say they are vasodilator responsive. And that's important because if you haven't appropriately classified the person, you may end up putting somebody on calcium channel blockers when they have a very small chance that they would actually respond to it. So our gentleman was not vasodilator responsive, which means he is WHO Group 1 and is not vasodilator responsive. And particularly in WHO Group 1, there are several different subcategories. Idiopathic, heritable, drug and toxin associated, and then associated with other conditions such as connective tissue disease, HIV, and the other things you see there. In him, he did not have a family history of disease, and so we didn't think that he fit into the heritable condition. He had not taken any of the drugs associated with pulmonary arterial hypertension. And you may be aware of fen-phen and some of the cardiac problems that it caused. It has also been associated with the diagnosis of PAH. He also did not have any of the findings of scleroderma or other connective tissue diseases, and his labs didn't suggest any of the other problems listed there. As a result, he ended up being classified as idiopathic PAH, WHO group 1.1, and was not vasodilator responsive. So the next question then would be, how are we going to treat him? It's important to understand a bit of the pathophysiology and pathogenesis of the disease to understand how best to treat people. Most people, most of the conditions have been associated with some sort of risk factor or underlying condition, whether that's a collagen vascular disease or HIV or drugs and toxins, and there has to be some inherent susceptibility to a patient. We know about a few of the genes, but then there must be some other genetic factors that are there, because not everybody who has HIV develops pulmonary arterial hypertension. Not everybody that has scleroderma develops it. Ultimately, this combination of risk factors or other conditions with the underlying genetic susceptibility combine to cause vascular injury. And there are three key pathways in this vascular injury that have been implicated in the pathogenesis of the disease, particularly low nitric oxide production, an imbalance in the prostacyclin thromboxane ratio, and high levels of endothelin-1, with endothelin being a potent vasoconstrictor. What happens is that the endothelial cells lose contact inhibition. Normal endothelial cells try to touch each other as little as possible. So if you put them into a media and try to get them to stack up, they simply won't. They try to keep as little contact with the other cells as possible. In PAH patients, they lose that contact inhibition, and as a result, they'll get stacked up. And as they get stacked up, the underlying smooth muscle has to hypertrophy to deal with the pressure load. Ultimately, you end up, as you see on that right-hand side, with these evaginations of the endothelial cells just after a branch in the pulmonary artery, where to the point they almost look like the glomeruli of kidneys. Because there's lower flow states, you end up seeing clot forming or in situ thrombosis. So this pathogenesis of PAH invites treatment at three particular chemicals: nitric oxide, prostacyclin thromboxane, and endothelin. I use prostacyclin and thromboxane together because they are of a similar origin, and that balance between the two is really what's at fault for the development of the disease. So how best to treat them really depends on their risks, because some of the treatments are more challenging, expensive, and riskier than the others. So you need to risk stratify patients. In addition to the right heart catheterization with vasodilator testing, the respiratory therapist helps us out a lot in the risk stratification of patients. This is a table from the REVEAL registry where they followed patients to see what predicted a worse outcome. People who had right heart failure clinically, who were rapidly progressive, who passed out, whose functional status was poor, all tended to do worse. A way to quantify the progression of symptoms is to follow their 6-minute walk test. You see the values there that suggest a low risk, intermediate, and high risk of disease. And we're going to talk more about the 6-minute walk test because I think it's an underappreciated but very important test that Respiratory administers for us. You can also do formal cardiopulmonary exercise testing, and I'm not going to spend a lot of time talking about it because the 6-minute walk test is just so much easier to do. For the 6-minute walk test, the American Thoracic Society has clear standards for its administration. The importance of doing it consistently is that there's a lot of variability to the test, and it would be nice if all of the variability were related to the patient. So if we take the same approach every time, the results should be independent of the place that the test is done, the person administering it, etc. And the ATS says that you need to do this indoors, and it needs to be a infrequently used corridor of at least 30 meters with clearly marked start and turnaround point. Patients should rest 10 minutes prior. They shouldn't have just run up the stairs, and you start off measuring their vitals. Pulse oximetry is optional. You don't actually have to follow pulse oximetry, and it's really the distance that somebody goes that we follow most closely. Patients stand up, they rate their dyspnea at baseline, and as you'll see in a second, they also rate it at the end. Hypoxemia is not a reason not to do the test unless it's causing them problems. If they're having hypoxemia to the point that they actually have chest pain or they're just so short-winded, then not doing the test or stopping it at that point would be appropriate. Leg cramping, staggering, clear diaphoresis or ashen appearance, that would obviously be a reason to stop the test. The ATS has standardized boilerplate instructions that, again, are supposed to remove some of the observer bias that may happen. And this is the dialogue that they suggest, that you explain the test using these terms, let them know that they should walk as far as possible, as far as they can go in 6 minutes, but they can't cheat and run or jog. And I have a couple of patients who actually have tried to do that. And then you start them and you have your stopwatch to make sure that they go. At the end of the test, using a Borg scale, you ask them also to report what their dyspnea was, and also to let you know why they stopped going. While they're doing the test, you can't cheer. You can't sort of encourage them. Keep going. You're almost there. There's only a certain amount of time. The respiratory therapist really ought to be saying, you're doing well. You have 5 minutes. Keep up the good work. 4. And you see the dialogue that ought to be there. And it really, that is all the communication that ought to happen. And again, the goal is to reduce bias so that the results are more reproducible. Again, you should document why they didn't go further. And there's a fair amount of variability in the test, both within a session and within a day and across a week. But if someone's 6-minute walk test is falling by more than about 10 to 15%, that would be concerning that their pH was getting substantially worse. So it's helpful to have the results of prior tests when you're trying to figure out what to do with the results of the test that you did that day. So treatment options, as you risk stratify people, you then have to consider what drugs are most appropriate. And as I said, there are 3 pathways that you target. One is the low prostacyclin, and there are prostacyclin agonists out there. Then the high levels of endothelin, and there are endothelin receptor antagonists. And then low nitric oxide. There are ways to supplement the nitric oxide that is available. Particularly, there are 2 nebulizers that deliver prostacyclin analogs, and you see them highlighted there. And so the respiratory therapist, again, has a significant role in teaching patients how to use these unique nebulizer setups. They're not the conventional ones. They're very dose controlling. A non-medical approach to therapy is pulmonary rehab. And obviously pulmonary rehab is a comprehensive intervention that's really tailored to a particular patient that includes exercise training, education, and behavioral interventions. And respiratory therapy and pulmonary rehab, the respiratory therapist plays a key role in the pulmonary rehab programs. The data that we have about pulmonary rehab and pulmonary arterial hypertension is somewhat limited, but it's very promising in that we see significant improvements in their people's VO2, their 6-minute walk distance, as well as their quality of life. And in some of those studies, it suggests that the pulmonary rehab interventions may be as potent as some of the medications. And as a result, this is something that the respiratory therapist can really help out with. So returning to our patient, he ended up being treated with Flolan, which is epoprostenol, and a PDE5 inhibitor, which is a drug that blocks the breakdown of nitric oxide, so the nitric oxide levels are lower. So the nitric oxide levels get higher. The graph on the right is a graph over time of his B-natriuretic peptide. You see when he first started on therapy, his B-natriuretic peptide, or BNP, had gotten up to 3,500, and shortly after getting treated, it fell to well less than 1,000, and he had a sustained response to it. You may remember his 6-minute walk test was 300 meters, and by the time that he started medical therapy, he was down to about 200 meters. And here we'd gotten him back to 360 meters. So as I said at the beginning, PAH is one of those pulmonary conditions that you can make a substantial difference in people's quality and duration of life, and I think he's a good example of that. By the time we started him on therapy, he was functional class 3-4 in that he was dyspneic at short distances and almost at rest, and he really had a lot of right ventricular pressure and volume overload. And then by the time he was on maximum medical therapy, he was back to what is effectively a normal exercise performance. So all of this has been based on, patients in the outpatient setting. It's worth talking a little bit about patients who have pulmonary hypertension or right heart failure in the ICU, because especially when it comes to ventilating them, they're a relatively unique population. Oxygen, of course, is a pulmonary vasodilator, and so it's never inappropriate in the PAH patient. It's important to recognize if someone's developing respiratory failure and is going to need invasive mechanical ventilation, that the drugs that we use to facilitate intratracheal intubation may actually impair cardiac function, dropping people's systemic blood pressures, and may worsen the right-sided hemodynamics as well. And so you have to be prepared for that. It's important to know their volume status before you sedate them, so that if their right ventricle is particularly preload dependent, that they have the right amount of preload, but then at the same time, if their right ventricle is volume overloaded, recognizing that additional volume may actually be deleterious. Once you're applying positive pressure with a mechanical ventilator, it's important to recognize that you're going to be changing their hemodynamics. If their RV is preload dependent, having too much intrathoracic pressure may impair RV filling. Same thing with the LV. And if you apply too much pressure, you may actually increase the RV afterload and actually cause acute right heart failure. And if you have too little support, you may increase pulmonary vascular resistance through hypoxic-mediated mechanisms. This is a nice graph of that effect, that if you have people who are undersupported, they have a small alveolar surface membrane, the result is hypoxic-mediated vasoconstriction, and their total pulmonary vascular resistance is high. And then as you apply positive pressure, particularly over distending the alveoli, you compress those capillaries, and their PVR comes back up. So you're really looking to ventilate people really in that sweet spot where the PVR is maintained at its lowest point. So in summary, the respiratory therapist really plays an important role in the management of these patients. They play a role in the diagnosis of PH because those PFTs are essential to the accurate diagnosis of their pulmonary hypertension. The respiratory therapist is essential in appropriately risk stratifying the PAH patient, helping with the right heart catheterization to figure out whether this person is vasoresponsive, which will help determine therapy, and also in administering the 6-minute walk test so that we understand how debilitated the patient is, and we follow how what they're responding to therapy. They're also important in the treatment of the PAH patient in that the various prostanoids may be available as nebulized therapy, and that's particularly important in people who have limited manual dexterity. The scleroderma patients often will have Raynaud's and the like, and they can't do IV therapy, and so they have to do the nebulized therapy. And then children, of course, don't do all that well with IVs, and so the prostanoids as a nebulized treatment may well be the best option for them. Respiratory therapists also, through pulmonary rehab, play an important role in the treatment of PAH patients. And when it comes to ventilator management in a critically ill PAH patient, the respiratory therapists really, through their understanding of the interrelationship between hypoxemia, acidosis, intrathoracic pressures, ventricular filling, and RV afterload, will help give the patient the best chance they have of surviving their critical illness. With that, I will take any questions.
Thank you very much, Dr. Walter. We have a couple of questions about treatment. So I'm going to go back to this slide of yours about ventilator or vasodilator responsiveness. And our first question is about the cost of inhaled nitric oxide. I think that every respiratory therapist who has given nitric oxide in their career has been pounded upon by their managers about making sure the tanks are turned off and making sure we're not wasting the gas because it's exceptionally expensive. So do you have a specific reason for starting with your protocol with nitric oxide versus an inhaled vasodilator like epoprostenol?
So epoprostenol is about $100,000 to $150,000 a year, and so it has its own cost challenges. No one's ever done it as nebulized therapy for vasodilator responsiveness. They've only used it in the treatment. So it has its own cost. The pharmacy has to make it up. The dose that you would be using wouldn't even use it. You would end up wasting a whole bunch of it. So it has its own cost challenges. The amount of time that we're talking about with a vasodilator challenge is only about 20 minutes. So the total cost in an individual vasodilator challenge is not that high on the nitric oxide. The adenosine is a cheaper option, but again, it involves the pharmacy. And has, in our experience, has ended up tying up the cath lab for time, and the cath lab's costs are not inconsequential either. And so for us, it's just proven to be sort of the most cost-effective approach.
So I think that the take-home point here is that we have to make a distinction between what we're doing in this situation, which is simply determining whether or not there is a response to the vasodilator versus actually treating pulmonary hypertension.
Right. This is a risk stratification to see whether or not this person likely would benefit from calcium channel blockers, and the period of administration is only on the order, it's less than an hour.
Got it. And that makes sense. I think that as respiratory therapists, we don't see this particular phase very often unless we are assigned to work in the cath lab that day. We see more the long-term effects of keeping the person on nitric oxide or setting them up on the inhaled vasodilator. So it's good for us to understand the two distinctions of and uses of those medications. Do we have a sense on whether or not the application of CPAP or non-invasive ventilation would improve or worsen this patient?
So they don't have a ventilatory failure in that their PCO2s are normal or low. They have they have hypoxic respiratory failure, and that's not, hypoxemia is not usually the problem. What kills patients with PAH is actually their right heart failure. So much so that, in fact, if someone is like at end-stage disease, they're failing medical therapy, they're awaiting lung transplantation, one salvage approach, or at least hopefully buying you enough time, is actually to go out and open up a atrial septal defect by opening up the foramina valley. And the effect of that is that the right atrial pressure is so much higher than left that you dump all this unoxygenated blood over into the left atrium, effectively creating a huge intracardiac shunt, and they become much more hypoxemic. But because their cardiac function improves, it actually, at least for that period of time, they are hemodynamically doing better. Now, their sats may be in the 60s, and it shunts, so you can't do a whole bunch about it in terms of applying oxygen in the lungs, inhaled oxygen. But at the same time, they're dying of heart failure. And so the hypoxemia is not as big a problem. If you have somebody who's developing, who has PAH and is developing worsening hypoxemic respiratory failure from a more conventional thing like pneumonia or something, then yeah, applying positive pressure with understanding that you're increasing intrathoracic pressure, so you want to make sure this person's volume status their intravascular volume status is appropriate. Then recruiting strategies, that kind of stuff, would be very appropriate, because the hypoxemia is adding to the pulmonary vascular resistance in that case. So the stable patient, CPAP and all, is not helpful. And the patient who is deteriorating because of a secondary process like pneumonia or something, then treating that second process that's going on with positive pressure ventilation, whether that is CPAP or non-invasive ventilation or invasive ventilation, by reducing hypoxemia, reducing hypoxic-mediated vasoconstriction would be useful.
So if the patient had a secondary issue, the appropriate application of the non-invasive ventilation wouldn't be a detriment to his pulmonary hypertension status.
Right. So my advice, when patients undergo general anesthesia or they end up in the ICU, my recommendation if they're not in our institution, my recommendation is that people make sure that their filling pressures are appropriate, and then just ignore, to the best of your ability, the pH and treat the other stuff, because the other stuff may well be what's killing them, and that's really what you got to focus on.
So we have time for one last. We have time for one last question, and this is for one of our viewers who is a respiratory therapist at a critical access hospital. If we have a patient come to an ER at a critical access hospital and we're waiting for transport to survive, what are the key issues that emergency department team needs to focus on?
So if they're on therapy, the most important thing is to not interrupt therapy. Some of these patients are on continuous IV infusions, and they might be hypotensive because they have like a catheter-related bloodstream infection or something like that, and it gets tempting to turn down or turn off their epoprostenol. Interruption of PAH therapy has been associated with acute right heart failure. The right heart has gotten used to not having to work so hard, and all that hypertrophy that it built up has gone away, and then taking away the PH medicine makes it so that demand goes back up. So the most important thing, if they're already on therapy, is to not interrupt it. If somebody has untreated PAH and they're that sick, then it's just very important to get them to a center that can consider things like VA ECMO or something like that as a bridge to treatment of some more definitive treatment, whether it's cardiac transplant or IV therapy. Will depend on the patient in particular.
Wonderful. Dr. Walter, thank you again for joining us today.
Thank you.
And thanks to everyone who joined us. We hope that you will come back and join us again on June 27th as our Summer Disease Series continues. We welcome Dr. Dee Dee Gardner for a session on childhood asthma, attendance, and action plans. And on July 10, we wrap up the session with a presentation about alpha-1 antitrypsin deficiency with Dr. Robert Sandhouse. Again, thank you for joining us, and have a great day.
All right, I'd like to thank our speaker, Bob, for sharing his expertise, and I'd also like to thank our participants for your interesting questions. In just a moment, you will see a Submit Credit button on your screen. If you are an individual who is registered for this program, you will go through the credit submission process on your individual account. Should this button not appear, please navigate to the Credit tab and select the Click Here button linked. If you are a group participant, please have your group leader submit your information to the Group Attendance tab to be provided with follow-up instructions on how to submit for credit. This concludes today's presentation. To end, simply exit out of the browser window